And I am very delighted to be here, the organizers invited me here, I used to be with Dr. Han Wang, at the temple. I came back Tianjin Medical University 4 years ago. And here, some work, you can see I still have, both Tianjin Medical University and, temple, because actually part of the work was done, in Philadelphia. So actually my topic looks like change a little bit. I actually changed to right heart failure. Okay, so just want to give you a new story because I want to share with you guys. Excited. And that's my overview. I don't want to bother with you with that. And that's my scientific question. So this is actually a very typical EC coupling cartoon. I purposely, select a review actually back to 2010, because, as you guys know, I have been working with cathode handling and PKA signaling for a while. So today I put it here, because I'm talking about PKA. And, back to the days, we believe that when beta genetic receptor is activated, actually will increase the intracellular cyclic AMP. And then, increase the EPAC activity and cause chemical 2 activation directly. And actually, we have some work showing that actually not true. And also some other work also showing that, chemical 2 can be directly activated by GS alpha. And I can tell you that also not true. We have a story, I'm going to tell you. So the second thing is actually just what I have been working on. Half my life actually was working on, cathode handling and cathode overload, inducing cardiomyocyte function, discharge or myocyte death, arrhythmia, hypertrophy, blah, blah. And then, we also worked on, physiology, EC coupling. And recently I use PKA inhibitor peptide as a tool to probe PKA role in the heart or cardiomyocytes. Because PKA is such an old, molecule in the heart, actually I always got a question, so why you're studying it? But, I always trying to argue is that actually we don't know a lot of, the PKA. We know association, we have no clue, the really, the cause effect. The reason for that is because PKA has 3, genes encoding the catalytic subunits in the myocytes, and then you cannot knock out all of them, especially you want to be tissue specific and, inducible. That means you have to get 8 genes in the same, cell. That's almost impossible. So we actually made a very interesting, I will tell you, when I talk about method. So that's my question, do we really know, everything about PKA in the heart? That's actually not true. And also, if we inhibit PKA, does it cause reverse or adverse remodeling? Or if we really, can we use PKA inhibition as a rule, a way approach or an avenue to treat heart failure? So just my animal model actually has been published, and we basically have inducible PK, inhibitor peptide overexpression in the myocytes. We actually have that, and it's a TET-off system. So you need to put dark cycling on it, the genes turned off. If you have dark cycling off, it will be on. Just actually, you will see, we actually got 3 lines, low expression, middle expression, and high expression, and then you will see PK activity is inhibited by 70%, or 30%, 70%, or almost completely. So you see the heart, because it has been GLP tagged, so it's green, and the myocyte is also green. So actually when we tried to publish our paper recently, that they said is PKI is really specific, so we did the kinome screening. So what we found is that actually you screen the kinome, actually the company did it for us, and then you only PKA or PKX, which actually part of the PK family, is inhibited significantly. The other kinases not inhibited significantly, because there's a 10% actually is you can say the boundaries or the detection limit of the method. So what could happen actually, normally I put this at the back, not necessarily in the front. But what would happen if we really completely knock out the PK activity in the heart or in the myocyte? I didn't show you the whole story because it's already published. So I just want to show you that if you really knock out PK activity, you will see that you infuse different doses of ISO, you will see the heart rate not change. That's actually contradict what you learn from the textbook. The textbook will tell you that, if you have increased cyclic MP, where you activate the funny channel and where activate the heart rate, increasing it, and you will see the contractility or DPDT, is completely blunted. Also, the minimal DPDT means how fast the relaxation is completely. You can see that, if you from here, you can see the DPDT, you can see here you have the dose response, here you have a flat line. So basically, that's what you're going to see. So if you inhibit PKA, what could happen, right? And the reality is that back to a couple of years ago, somebody knocked out the PKA catalytic subunit gamma and found actually it's good. And what we found is also interesting. We traced for the mice for 12 months. You will see that the heart didn't get really dilated that much, like the black line, the solid triangle. You can see that don't dilate that much. Also, the cardiac function always higher, but there's no change of the diameter or the thickness of the walls. So this actually really is good. And one thing is that everybody knows if PK activity decreased, and then myofilament phosphorylation is really decreased, and the calcium sensitivity is increased, it would cause the relaxation issue. And we look at it by look at the EA ratio, and you look at 6 months, 12 months, don't see difference in EA ratio, or don't see the EE price ratio. EE price is the standard for the golden standard for quantitation of relaxation of the heart. So if you look at the heart, you don't see the difference. You don't see HE. You don't see anything here. Pretty much the heart is normal. And that's what we basically trying to tell you. Actually, PK is a major mediator of beta-adrenergic responses. Other molecules play a little role. And complicase 2 actually is downstream to PKA. And cyclic MP inhibition, it can enhance beta activity. And actually, I didn't show you that later on. We will show you. And the long-term some PK activity inhibition doesn't cause adverse remodeling. So that actually set the space for us to try if we inhibit PK can be an approach to really treat heart failure or hypertrophy, because now I can completely knock out PK activity, but still no detrimental effects, right? That's my point. So what we're trying to hear, this is an unpublished study, and then we use right heart failure. As everybody knows that pulmonary hypertension actually is really detrimental and cause a lot high mortality, and currently believe that the PPH-induced mortality is mostly because of the right heart failure. So as we have shown you that we have the mouse, right? So we just use a pack with pulmonary artery constriction, not like under artery, not under transaortic artery, it's pulmonary artery constriction. You will see that if we really cause, we normally know that, right? The pressure, the systolic pressure of the right, ventricle actually is about 25 millimercury, and actually we can increase almost like 60. It's huge imposition of pressure on the right ventricle. And if we really have the red line is the PK inhibition, we say the wall not really thickening, or the diameter not dilating. And also you don't see much, not as a severe decrease of the function, or the hemodynamics. You can see that also is much better preserved in the PK inhibition mouse in the right ventricle. And then if you look at the hypertrophy also is significantly blunted. So basically that's actually repeats what we saw actually in the left ventricle we just published in early this year. And then, that's push us to really the next point. We're trying to do gene therapy. So we basically make a pack model, and then, use the week 4, we basically inject AAV and then look, the function, tracing it. And what we found is that, we inject AAV at week 4, you will see that the function is really significantly improved. And also, the wall thickness or, the hypertrophy also reversed. And then, if you look at the heart, say that if you treat it, you will say, even with PAC, don't say significant hypertrophy or, fibrosis, or, the hypertrophy is myocytes, cross-sectional area wise. And then, if you really inject PK, and then, basically, PAC is only one model. Another model we used to use for PAF, actually PH is Sugen hypoxia. You will see the same thing. We inject, AAV at 2 weeks after we induce hypoxia Sugen to induce, PH. You will see that actually again, you will see once we inject AAV, and you will see the function is much better. and the wall thickness is decreased, and then, the movement of, the tricapsid, valve is also much better. So the hypertrophy also reduced. So we basically use two models to show you that once you inhibit PKA in the cardiomyocyte in the right ventricle, you will see have much benefit effect for, the heart. And this is basically what we show you that, again, at the tissue level, you don't see, much hypertrophy once you have PKA inhibition, and the same thing. So now we come to the mechanism, and then we basically use a PAC model as the only, model. You will see that we have shown a PAC and using PKA inhibition, but this is induced by, the AAV gene therapy, method. So you will see that pretty much like what we found with transgenic mouse. Once you have PK inhibition, you will see the phosphorylation of a lot of molecules used to be believed to be detrimental in the heart. Actually, once we have PK inhibition, you will see they don't get increase anymore. This, the Shen and versus in PAC, you don't see increase. So you pretty much you see the over phosphorylation induced by PAC is prevented by PK inhibition in the right ventricle. And look at the cardiomyocyte level, you will see the function is better, because I was trained as a cellular physiologist. And then, we look at the cell, you look at, the Shen cell, and look at, if we only have the Shen surgery plus, PK inhibition, you will see that. You will see actually once you have PK inhibition, the myocyte contraction a little better and contract slower and relaxation slower. But once you get a PAC on, you will see the control mouse, the contraction is decreased from the black line to the blue line. But for the PK inhibition mouse, you will see from the red line to the green line, you will see much better function. Actually, just the statistics. I don't want to bother you with that. And then just what we found actually, if we really found why the myocyte are phosphorylating, right? We know that HDAC and NFAT plays a very important role, right? So HDAC, normally we need to dephosphorylate to get out of the nucleus to really permit hypertrophy, right? What we found that is if you really have the you have in the PAC induced in the Shen mouse or GLP treated mouse, you will see HDAC phosphorylation increased, and then in this PK inhibition mouse is not increased. Again, NFAT is the same way. NFAT, as I just mentioned, is supposed to be decreased phosphorylation. And you will see that once you have in the control mouse, you have decreased phosphorylation, but in the treated mouse, it's not really decreased. So just what we're trying to show you that we really can inhibit the hypertrophic signaling. So once you also look at the cell death, you will see that once you have PK inhibition, you will see there's less cell death in this PAC group, and that's what we did. Statistically, you can see much decreased. And also look at the inflammation by HE. You will look here. In the control treated, you will see a lot of infiltration of inflammatory cells, and here you only have some. So that's what we found that. And we also look into, look at the mRNA expression of all those inflammatory factors. You will see they're all decreased by our, PK inhibition. So at last, we really look into, the RNA or, transcriptome. You will see that most of the metabolism-related genes actually upregulated versus, the PAC with, only GLP. You can see that mostly the actually metabolic genes. And the other genes actually decreased, actually some of them is really, related to inflammation. So in short, we're trying to tell you that we basically beta adrenergic activation can cause PK activation, and through this, AKT or GS3 alpha beta mTOR signaling, increasing protein synthesis, and also it can increase autophagy or increase the proteasome degradation. But once you have that PK inhibition, you can cause the NFAT, HDAC, phosphorylation change and inhibit hypertrophy. So that's what we really want to show you is that PK is really the major effect of cardiac beta adrenergic responsiveness. And it doesn't, if you inhibit it, doesn't cause adverse remodeling. So in short, we're trying to tell you cardiomyocyte PK inhibition is able to prevent cardiomyocyte hypertrophy, death, inflammation, fibrosis, and failure during RVH and RVF development after patch or pulmonary artery hypertension. So thank you very much. This is actually my lab, in the US, and I just closed my lab last year, June. And here is my current lab, and we get, quite some collaborators, and, I really enjoy collaborating, as, Dr. Tao said, just like you young guys, trainees, please, open your eyes and collaborate. And also I'm looking for collaborators too. So if you have interest, please. And here are all my friends, I know. So thank you very much.